growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, you're tuned in to The Lionhearted Dentist, and I'm your host, Dr. Steve Rasner. Welcome back to those of you that have been listening for a while, and welcome aboard to those new ones. I hope you find this an arena of information that you can use tomorrow to make the shortest journey to practicing in a lofty zone that a lot of us never get to practice in. And that means going to work and feeling that you are surrounded by appreciative staff, by appreciative patients, that you are doing challenging, productive, and profitable procedures. And this is for the soldiers out there, like lions, who don't want to give in. I'm going to tell you a secret tonight. I've never tried to tell you I don't take any insurance. I've told you my associates definitely take some insurances. And I have clinged for years onto one, a large one that starts with a D, that is really a bully, but I released myself from them recently. And I got to tell you, it's been an eye-opening experience. It's really something wrong with the way, in my opinion, the way they conduct business. How they send out letters to all your patients convincing them that they can't come to you anymore, which is not true. They can come to you if you're out of network. They just don't get paid as much by going to an in-network dentist. Why not just say that? Isn't that fair? Isn't that truthful? It's almost like they are bullying my patients now, like they have my colleagues for years. I'm pretty mad about it, but that's not the topic. The topic of the podcast, and I like to give these on the days I work as opposed to the weekends, because I'm so full of live interactions that you deal with too. And I think I come off more fresh, more relevant. And so the last couple podcasts, as you know, I've been trying to give you the superstructure of a super productive solo practice. Like, how does it happen? I've told you I've done 140,000 collections on a given week. And you know the numbers I've given you before for a year. And I would think at times you might say, how? How do you, I hear you say it, Steve, but how do you do it? So that's what the last couple podcasts have been about. And I'm really not done with that subject at this point, but I wanted to break it up tonight. And I wanted to talk about something else. And I think you'll love this. And the topic is, why do your patients say no or yes to your treatment recommendations? And this thought occurred to me on my drive into work today. You know, what is it that really makes or breaks a patient saying yes or no to you? And if you think about it, that goes along with the last couple podcasts, because I gave you a lot of information about the importance of the team and about being organized, about having protocols. And we started to touch upon branding and marketing. All that has everything to do with what kind of numbers you're doing each week. If you're marketing that you're the emergency dental center, there's a fellow that practices within 40 minutes of where I'm talking to you from right now. And his thing has always been that he opens from, I think, 8 o'clock at night to 8 in the morning. Maybe he does well doing that. I wouldn't know. But that's not what I signed up for. And that's not the lion-hearted dentist, if you ask me. So part of this, for sure, is what's happening in that moment of truth where you face either an existing patient, a returning patient, which are the best, by the way. That's why you always have to have an effective recall program going on in your practice. Because no matter who you are, we all lose people out the back door, meaning they don't reschedule or they call to cancel and nobody can explain how they're not in the schedule anymore. And I'm talking about good patients too, patients you've done big cases on. How does that happen? Because no one in the office took that call, right? Where the patient called and canceled and nobody rescheduled that patient, but that didn't happen. Are you kidding me? So here's the point. I'm being obviously facetious because it perturbs me that, it happens in my practice. I mean, I have great patients overdue more than whether they're overdue the 4 months that they're supposed to come in or the 6 months they're supposed to come in. And I'm talking quality patients. And not all of them. Some of them are putting us off on purpose. Some of them just got busy in their lives. So recall patients are a big deal. Let's not minimize that. So getting back to that moment of truth, when somebody needs something, and particularly if it's a new patient, which is going to be the gist of this podcast, why do they say no to you? I'm going to tell you why. So, and if you're doing any of these, anything I'm about to give you is pretty fixable. And if you're not sure, you should dedicate a staff meeting to this particular subject. Subject should be, why don't we get more case acceptance? I mean, that's a big part of why I talked about the anatomy of a super successful solo practice. Because the percentage of people that I recommend treatment to say yes. What do I think is important? Well, let's get to it. The first thing I think is really important is that you have a system in place for that initial call so that they know what to expect when they get to your office. Because I'd rather them not come if they won't allow me to do the basics. And the basics include, no matter why they called, I'm going to do a comprehensive full exam. And I'm going to take whatever diagnostic radiographs, models, whatever I think I need to give them a treatment plan. Now, there's ways to say that on the new patient phone call. If your new patient phone call is, hey, I'd like to get in to see Dr. Rasner. Do you have anything open on Tuesday afternoon? Sure, here's at 2 o'clock. What's your name? Telephone number? And maybe you go through the insurance information or maybe you don't. Maybe you're happy because you had a 2 o'clock opening tomorrow. Well, man, that doesn't work for me. We have the same amount of hours in the day to use these two things called our hands. And part of that time that you spend as a dentist is seeing a new patient and presenting recommendations to them. So I'm not even going to get into tonight the art of the exam that we've done many times on these podcasts. I'm going to get into why they say no or yes. So are you set up to fail from the beginning? I mean, I've had multiple moments in my career, earlier in my career, where hygienists came to me and said, they won't let me take any x-rays, or they only let me take the one x-ray. Well, that's a system breakdown in my office. Or what about trying to get the significant other there for that first visit? If you give the treatment plan recommendations of your life, honest, earnest, conservative if possible, and for whatever reason, what they want totals something north of, I don't know, I think the magic number is 5,000 in your office, and the significant other is not there, you're going to often run into a problem, a road bump. And I would tell you that if it's that patient and there's a way for you to reschedule with a significant other, you have a much better chance of getting that case than if they didn't come with a significant other. I mean, listen, what are they going to do? They're going to go home to their spouse. The spouse is going to say, hey, how'd you go at Dr. Rasner's office today? Terrific. I love the place. I assure you this happens to me and to you. And at some point, are you kidding me? They're not going to ask, what's the treatment going to cost? And if it's 10,000, 12,000 even, let alone 20,000, that's just not going to fly in most households that did not get the chance to meet you, to hear your sincerity, to understand and feel there's a difference in your office and that everything made sense according to the parameters of that visit about what the patient needed, about what you had to say. So you have to be set up for success for starters. Another reason is that there's no connection with you or your office. So remember something, what I just said. I said it's unusual, did I not? For most patients that presented with a comprehensive treatment plan, when I say comprehensive treatment plan, I'm not talking, I had a patient in my chair today and yesterday where they had old amalgams. They had to be 25 years old. I could not see decay on the x-ray. They looked okay in the mouth. They didn't look great. They had many needs, these patients, that superseded the need to change out their amalgams for a newer restoration. That's not how I operate. It isn't, unless there's something obviously flawed with that restoration. And I tell the patients that. And that makes them feel safe. That makes them feel that I'm not going to be ultra aggressive in trying to get that mouth up to Steve Rasner's standard of care if there's nothing wrong with what I'm looking at. I'm talking restoratively right now. Nor will I try to force replacement of all teeth on a patient unless I believe the loss of that teeth at that time is deleterious to that patient's present health. They got a molar missing for 20 years and some shifting went on with the tooth behind it or in front of it or above, but it's stabilized in my eyes. Or you think I'm going to upright those teeth and do a ramus graft and the average patient appreciates that? I don't think so. And what's even worse, and I'm ranting again, I can't help it, is that the majority of the profession doesn't take a comprehensive care approach, so that when you do, unless you do it with a really sincere heart and a thought out approach to this patient, what you're going to say and how you say it. And if you're not sure, go back to my 6th podcast, I believe, on comprehensive treatment plan approaches. If you do that, then you'll hear that there is a way to make patients understand the value of that. Some patients, by the way, never have to pay anything out of their pocket, even when they're supposed to, because some dentists accept insurance as the fee, which is insurance fraud. It is. You can't do that. Anyway, when the majority of a body of population is not used to a thorough approach, it does make you possibly look aggressive. So I do everything I can not to be, is my point. But maybe there's no connection to you or the office. Think about it for a minute. They're coming into your office, and right now I'm focused on the new patient. They're taking a leap of faith. Don't you think that's foreign to them? They've been going to a dentist often for 10, 15, 20 years. Even if he's average, even if he's mediocre, that's where they're comfortable up until now. And now they're going to come to you. They walk in, they go through maybe your waiting room isn't spotlessly clean. That is important to me. Everything's important. Anything that new patient can visually see, whether it's the glass door between the reception room and the rest of the office, the outside door that they walked in, the refreshment center, or the trash can next to it, you better believe I got eyes in the back of my head, and so do you. You need to have them. Something doesn't look and feel fresh. A bunch of light bulbs out. Your chair looks beat up. I don't know. Or maybe it's much worse than that. Maybe you don't know how to look people in the eye. It makes you uncomfortable. Or maybe you have a staff member that brought this patient back and took the x-rays that just clocks in every day and is going through the motions. Maybe it's that. That something turns them off. Trust me, it happens. A new patient coming to my office or a returning patient is an event. It's an event that I need to win. And it's an event that I want to represent myself that way in my office anyway. And so should you. Do you talk slowly? Are you in a hurry all the time? Are you interrupted? You cannot interrupt me when I'm with a new patient. And that should be one of your protocols. For no reason. There's not one reason you can come in. I'm serious. Sometimes somebody will write a note and that makes me mad. And they'll hold a note out in the hallway. I'm dead serious. That's my moment with that patient and hopefully their significant other. I brought in chairs on wheels that are really comfy. They used to sit in my dental assistant chair, but I was always afraid they'd fall out. So I bought chairs 2 years ago. They're terrific if you have a little room. If you want to know, I'd gladly have Beth send you a picture and where to get them. They're terrific. They're nice, comfy, and everything counts to me, including that. Okay. Maybe they're turned off by the fact that in your office, it's okay to be loud outside the operatory, or that some other staff member is talking down to another staff member. I mean, is that a turnoff to everyone? And they hear that. So I'm talking right now about literally visual, palpable things that make you like any other office. Are you on time? We're early. We're early on a new patient. There is not a reason you can give me that you shouldn't have that patient. The moment they walk in, if they haven't filled out the paperwork, maybe they bring the paperwork back into the operatory. Now, there is a one-to-one interview with this patient. There's a whole system to this. And if you're not familiar with it, you need to get familiar with it, because I'll say it again. This is kind of a segue into my last couple podcasts, an offshoot, I mean. But I didn't want to hold on to it and finish the other. I wanted to give this to you now because it generated so many real thoughts to me that I think you're going to connect to. It can be any one of these things. All I am saying is that maybe they say no because there's a subconscious or conscious disconnect on any of the levels I just talked about. And the bottom takeaway from that is that you're really no different than any other office. Does somebody at the front desk even look at them when they first walked in? Was that a thing? In my office, what it is somebody walks out, they walk out behind the front desk and often shake their hand, smile, do a little dance. Well, they don't do the little dance, but I can tell you one thing. They feel a lot more welcome than I did 3 weeks ago when I went to a new physician. Because I walked in and I got the old glass window between the front office and the reception room. I was handed my paperwork. I sat there, I am not kidding, for 45 minutes, 7 o'clock at night. Finally went up to the desk and I said, do you normally have your new patients wait 45 minutes? I'm not going back. End of story. But there's other things that we have to talk about as well, which it could be. It could be a sense from them, and some of these are going to take longer to expound on, but I just want to outline them for you tonight so that you can look at them, and maybe write to me, by the way. It's drrasner@aol.com. Dr, my last name, no period, RASNER@aol.com. Maybe it's a lack of confidence in you. And then you have to work on that whole thing. You know, if you're up there saying, well, you can do this, or you can possibly, you got to have conviction of what you think they should do based on what they said they're there for, based on the options. So you know what I do? I'm just telling them, listen, I'm going to give you the pros and cons of a couple ways to fix this. Let's just talk for a minute about a terminal dentition. So I'll literally have a denture next to me. Now, I'll say something very colloquial that I know they get. I'll say, look, I know you probably know somebody that has a denture, But have you really ever seen a denture like in your hand? Because I'm going to give you one right now. And I put it in her hand. It comes from a model to my left. And I don't intimidate them. I literally educate them. Like LD Pankey said you should. And Dawson said the same thing. What could be better than them seeing a denture in their hand? Particularly a lower denture. And I'll explain why the upper stays in better than the lower. And I'll relate to them. And by the way, anytime I can give them good information about their mouth, I will. You know, maybe they have perio disease, but they have substantial bone left. And it's very treatable from my point of view. But certainly a lack of confidence in you is a buzzkill. It's over at that point. Would you say yes to somebody like that? Maybe it's a lack of understanding. I'm better than that than ever, and you need to be. I've got models. I have photos of whatever I might possibly cover. It's true. And certainly, it might be money. I mean, most of the population's not used to $10,000, $15,000, $20,000 treatment plans, and I don't even want it to be that. I walk my talk, and you should. If I can segment their treatment, and I tell them that, then I will segment it. We don't have to conquer Rome in a year. Now, sometimes you do. You can't treat part of a terminal dentition, but if you can do quadrant care on somebody or picking out the highest priorities, and I don't mean one crown. When I do a crown, a single crown on somebody, the very first thing that my brain from 39 years of this trains me to do is look at the adjacent restos if they're there, and do they have excellent contours, even if they're decayed or not. Because if they have flat contours and you're putting a molar crown in, guess what? You're going to have food traps and other things. So it's not egregious to do a DO on 29 and an MO on 31 if it'll enhance the restoration of the crown you're doing on 30. How else can you do that? So I give patients a lot of options. I want to expound on this next week if I can. I know I say that to you all the time, but I'm going to make a note as soon as I'm done tonight about, this is a good subject because I want to talk to you about in specifics where I think lack of confidence. But part of lack of confidence certainly comes from you not having a strong presentation, being too wishy-washy, not being personal. That's not a confidence thing. That's, you walk into the room and you're looking at the x-rays and you're doing that subconsciously because you're not comfortable looking at people in the eye, then you need to read some books by Dale Carnegie. I'm serious. I think the book's called Make People Feel, oh my gosh. Maybe Beth, you'll put it up on the screen for them. But there's videos on it. It's easy stuff. You know what you got to be more than anything, man? You got to be sincere. You got to really want to do high-level work. If that's what you want, then you have to communicate that to the patient. You want to be a safe haven for this patient, your office, where they can go and get an honest opinion. And if they can't do it, then that's okay. I mean, maybe they'll have to extract one tooth the next time they come in and not do any of the other work they need. Maybe it'll come down to that. You have to draw the line in the sand of what's okay for you. Are you going to do a crown if they turn you down for quadrant scaling and they need that? Are you going to be okay with fixing a front tooth but ignoring periapical pathology that looks ominous in a different part of their mouth? You don't have to replace every missing tooth. You don't have to do that at once. You don't have to repair restorations that have early failure. There is priority level care that you can do. And I try to. That's going to be it for tonight's podcast. I hope this stuff helps you. I think you need to dedicate a meeting to, are you getting enough case acceptance? And if you're not, break it down. You know, there's an old saying, leap and the net will appear. Leap and the net will appear. It means when you go in a direction with earnest intent and try to fix things, the answers start to appear before you. It's just that you haven't given it enough energy prior to this to make it happen. I know I make it sound simple, and it's not always simple. I get my heart broken a lot. I had a woman say yes to a treatment plan last week. I'll end with this. She comes in, she's 80-some years old, and she didn't need very much. She had good perio, and I said to her towards the end of the visit with me, is there any other concerns you have? I didn't even say, are you okay with your aesthetics? And she was a well put together woman, 84 going on 70. Dressed nice. You could tell she cared about how her presence was. And her aesthetics weren't nice. They were not nice. I didn't even bring it up. They weren't decayed. She wasn't missing anything. They just were yellow, older restos that were worn. It was a worn-looking dentition. Some abfractions. And she said, yeah, I don't like my smile. I don't like to smile anymore. Long story short, it led to a recommendation of 6 all-ceramic restorations in the front, which she seemed thrilled about. Pictures, before and afters, no heavy pressure. Trust me, that's not who I am. I'd rather them say no that day. And she said, yeah, and as you know, I get paid up front. And her visit was scheduled yesterday. And she canceled. And she had paid me. And she just said it cost too much. And she was mortified to cancel because she didn't cancel till the morning of, which I didn't love. I instructed my financial new patient coordinator. I said, you tell her, because we had taken models and photographs. I said, no problem whatsoever. You come in for your cleaning she was scheduled for a cleaning first. We'll give you back every dime that you signed on for and no worries at all. I told her that day in the visit, she looked great to me just the way she was. But if she wanted to enhance it, I was the guy for the job. Anyway, I hope you all enjoyed this. Have a great week and tune in next week to The Lion-Hearted Dentist with me, Dr. Steve Resner.